I'm Dr. Cooper Williams. I'm here at the Jekyll Center in Thompson Station, Tennessee, and I'm here to present the pelvic ultrasound of the horse, both inside and out. So moving to the pelvic roof, the first thing that I want to explain to everybody is I have my own way of holding the transducer that everybody I've taught this particular method to has liked it for being able to do this portion of the exam. But if you hold your index finger and thumb around the transducer like this and drape the cord over your wrist in this fashion, you'll find it very easy for manipulating the transducer on the roof of the pelvis and looking at all these structures. So I wanted to make sure that we looked at that first. So my first landmark, and we'll do this on the screen here first and then I'll move to the specimen, is going to be for the L6 disc. And so we're going to look at the L6 disc on the screen here first. That is my initial landmark every single time. So this is the L6 disc. You can see on the specimen that I'm positioned right about here. And so you're going to be positioning right on the midline of the horse, and the L6 disc is going to have an Eiffel Tower appearance. So on the screen, we'll come back here, we'll use our arrow. You can see, if you're looking at bone, it's going to be reflecting. If you're looking at penetration of the ultrasound beam through the bone, it's either a fracture or an anatomical space. In this case, you're looking at an anatomical space, the L6 disc. And again, it has this Eiffel Tower appearance where it's flared at the bottom. You have the cranial aspect of the ventral sacrum here, and you have the caudal aspect of the ventral L6 here that form into the L6 disc space here. Coming up, you can see the floor of the spinal canal and the dorsal arch on the other side of the spinal canal, and your cord will be running within this space, obviously. But if you get that window up to the dorsal arch, then that means you're getting a good window through the disc, meaning the disc is usually relatively normal. But you want to be able to look at the makeup of the disc here in this space. This should be a nice curve here at the base of the disc space that is not protruding. That's a normal curve to that. And there's the ventral longitudinal ligament that runs along underneath that whole area right through there. So what we'll do is we'll unfreeze that again, and we'll get that L6 disc space. And so what I'm doing now, and I'll do that up here on the specimen, you can see that I'm running back and forth across the whole vertebral body at that disc space. And what that allows you to do is, again, don't look for that one perfect image. You want to be able to make sure that you're able to image the whole disc back and forth. There may be an abnormal area on one side versus the center versus the other side, and so you want to make sure to fan back and forth. So then I'm going to split my screen, go back to dual, and I'm going to go forward cranially here, and we're going to get the L5 disc space. Get a really good image here, and then we'll update, switch to the other side, and this is called image blending. And so what we're trying to do now is to image the two side by side, get rid of a little bit of manure interference there, and try and blend those two images here. So here you can see the L5, we'll use our arrow again, it's the easiest. The L5 disc space is here. The L6 disc space is here. And so you're seeing the whole ventral aspect of L6 from disc space to disc space. The other thing you have underneath that in this region here, first I'll go back to our specimen, where you have the ventral aspect of the sacrum and you hit the L6 disc, everything goes in an incline upward from there on your image and on the specimen. And that area where it starts to go up is called the promontoire or premonitory. And you can see that on the image here, that corresponds to this incline in L6 coming up. So the sacrum is going to be relatively parallel to the upper part of your image. That's only the cranial aspect. And then from the L6 disc going forward, you will have, from this premonitory or promontoire, you will have this incline coming up to the L5 disc. And this area under here is where the sublumbar lymph nodes reside. And you don't normally see them unless there's an abnormality with those. So we'll then proceed forward again. We'll come back to the left-hand side of the image. Unfreeze. I'm going to get the L4 disc space on next. And to get that, oh buddy, run that back just a hair using the Cine Recall, which is a nice function. And we'll update, come back, and we'll blend that image again with the right-hand side. Oh buddy. So here you can see with the arrow that you're looking at the whole ventral aspect of L5. Here's the L5 disc space, and here's the L4 disc space. To put things in perspective here too, the L6 disc space you're able to see all the way up through into the cord and the canal. And with L5 and L4, you're not able to because of that promontoire or promontory and the angulation. You're not able to get perpendicular enough to be able to see up into those disc spaces like you do with L6. And the other anatomical structure that you see here, or two actually, you have two vessels. You have the aorta, which is a very heavy muscular wall, and so you can't compress that. And then you have the vena cava, which in this particular image, I have that compressed to be able to see further up into get the L4 disc space, and it allows you to get to that nicely. But the vena cava will not be visualized very well because of that compression. I'll bring that down, and what we can do next is we move forward. Let me show on the specimen first the L5 and L4. So you're going to come forward to L5 and then to L4 to be able to get those on your image. And that corresponds to what you see here on the screen. So then we'll unfreeze, and we're going to go back to a single screen again, and we're going to look at the aorta and the vena cava. And I'm not going to compress the vena cava now, but you want to watch the blood flow. So again, this comes under the heading of being methodical. So you can see the blood flow on these. I'll go ahead and unfreeze the image again. And you want to look for thrombi in this region. It's a common area of thrombi if they're going to have them. And the only way you're going to pick up on those is if you make sure that you're looking at these each time. So it's a good idea to watch that blood flow and just be in the habit. It doesn't take much extra time to do that. Then I come back to a double screen, and we're going to look at the iliac vessels as they branch off of the aorta in this region. So we'll go to the left on the left, and here you can see that branching of the vessels. And so we can screen off to where we're looking at iliacs on one side. We'll flip our image, and again go from aorta and look for the branching into the separate vessels. So again, I have them frozen here. You all know what a blood vessel looks like. It's better to look at those dynamically so that you're able to look at the blood flow. So then I come back to that L6 disc again. That's again always my home base. If you all are getting confused at any point in time when you're doing ultrasound, use that L6 disc space. That is your friend at your home base. You come back to that to be able to find everything else. So now I'm going to go to the lumbosacral intertransverse joint. And so if you look at the whole ventral aspect of the sacrum, each side has a wing that's similar to the transverse processes of the lumbar vertebra. And I'm going to simply go over the L6 disc and then move over sideways to be able to get the intertransverse joint. And that actually is a joint between the last transverse process of the lumbar vertebra and the sacral wing. And so on the screen here, again, we'll come back to L6. Here's the L6 disc, and I'm going to fan over to the side just a little bit like I did here on the specimen. And so again, L6, fan just a little bit off to the side. And we will be showing slides that show normal reference images. So we do have the chance that we're on our patient here and we're not seeing normal reference anatomy. And in this case, that I'm not seeing the intertransverse joint very well. On this side, I'm able to visualize it further out. That would be right here. You have, again, the bone surface. You see the foramen for the nerve showing up here. Near the foramen is going to be that intertransverse joint, but on neither side is that intertransverse joint showing up very well. So we're assuming that we were going to get reference images, but I will, on our slides, show normal reference images for that intertransverse joint. But again, on our specimen, coming up to here, you go from the L6 disc and you slide over to the intertransverse joint, just a little bit off the midline. And then from there, we're going to actually look at the nerve roots. And again, on the specimen up here, you can see that that's very close to the intertransverse joint. The foramen or hole for the nerve comes out at each segment. And you can see that with the camera. And on the image here, again, we'll go to the L6 disc. We'll fan off to the side, and you see a little bit of an arch of bone. And that's right here, this little arch. So you have the caudal gluteal artery is this particular vessel here. You have the arch of bone at L6 that the nerve root for L6 is coming out of. And you have a nice smooth bone surface here. We'll flip to the other side again and duplicate our images. Again, left on the left, right on the right. No magic to that. And here you can see the foramen show up, L6 on the right. And again, caudal gluteal artery, the foramen here, and the nerve root in between. There's no complicated anatomy here. You're just looking for those structures. And you can slide back to the S1 nerve root, which would be the next one back. So again, you can look at the L6 disc, go off to look at the L6 nerve root there, slide back, and the next foramen back is the S1 nerve root. You can see that here and a little bit of the caudal edge of the L6 nerve root. Come back to the other side. Again, go to the L6 disc, go to the L6 nerve root, and then come back to the S1 nerve root here. And you have those duplicated. So on our specimen up here, you can see that I'm going to be positioned just a little bit off midline to be able to get those foramini. So you can again come back to your image, and just to reinforce, the L6 disc is your friend, your home base. So slide off to the L6 nerve root, and you can then come back to the S1 nerve root, and then the S2 nerve root. These nerve roots get progressively smaller, so all you see is a little bit of an arch in the bone there. I don't usually freeze those images, but I will look at those as I come back. So then the next point is going to be the sacroiliac joint, and on our specimen, we're at the L6 disc. We slide off a little bit to get the nerve root at L6, come back to the S1 nerve root, and then we're going to travel laterally from there. And you can see on the specimen where the ilium and the sacrum meet in this caudal aspect. My transducer is going to be right in here and right in here. So you cannot evaluate the sacroiliac joint from the dorsal aspect. You must do this from the transrectal aspect, and we're going to do that on the screen now. So we'll again go to that L6 disc, which is here, and we'll go off to get the L6 nerve root here, come back to the S1 nerve root there, and then we're going to travel laterally and find the sacroiliac joint. And this is going to be quite variable between horses. What you're looking for is a normal J shape of the sacrum. And his is very shallow, at least at this aspect, but we'll go ahead and show this. So you have the ventral aspect of the sacrum here, you have the joint space, and you have the ilium over here. And you have, if you look on the specimen, you can again see on the roof here, the sacral wing is fairly long. It's a few inches long, and you want to be able to scan that entire sacroiliac joint. You don't want to just isolate one side. So I'll be fanning back and forth on that, but we'll go ahead and flip over to the other side. Again, getting the L6 nerve root, or I mean the L6 disc first, and then the nerve root, and then the S1 nerve root, and then you're going to again come just laterally from there to be able to match up your image to get the sacroiliac joint. Again, his is quite flat when you get into this section. And you don't have quite the beam penetration on this side that you had on the other side. But I'm going to go ahead and fan again, going off that S1 nerve root. And I can fan back and forth. And I actually do see a fair bit of proliferative bone on this aspect of the sacroiliac joint. You can see that right in this aspect here. You can see this knob of bone coming down on the right side. Go ahead and duplicate our image to the other side. Again, looking at L6 disc, L6 nerve root, S1 nerve root, and then going laterally again. And you don't have the same type of bone proliferation on this side. This whole side seems to be relatively normal. So you're not able to duplicate that image from side to side. Not that they can't have pathology on both sides, but it's nice if you get a fairly good reference image on one side and then you can go to compare to the other side. So then what we're going to do is on our specimen, I'll show you, once you're on that L6 disc, you can actually go down to about 3 o'clock and you're going to image the minor psoas tendon. So the psoas muscles are the ventral back muscles, mainly in the lumbar region. And the tendon that comes from those muscles is going to attach onto the ilium. But you can actually scan that tendon by just rotating your probe around to about 3 o'clock and to about 9 o'clock on this side. So we'll do that on the screen here. And here you can see tendon tissue showing up. Right in through this area, you can see nice dense tendon fibers. And we'll do the same thing on the other side. And so these are the tendon attachments for the psoas muscles. And we'll pull our arrow up here. Again, nice dense tendon tissue, and then comes back to attach at the caudal aspect here and here. So these are two normal tendons. The other thing you can see on the screen is just a little bleb of the femoral nerve root right above that tendon. And the reason I'm pointing that out is because if you remember, if horses have a slipping injury where they all of a sudden slide out behind themselves, they oftentimes, with a really severe slip, can get femoral nerve paralysis, whether it's temporary or permanent, and that's because that nerve root goes over top of that very dense, sharp tendon, and so that sometimes can injure that nerve root right there. The other thing that I do is I will go back to single screen, and from the L6 disc, I will survey the ventral aspect of the sacrum, and it has, as you can see on here, it has an arch shape to it from the L6 disc back to where it meets the coccygeal vertebra. And I just simply look for a contiguous bone surface like this on the screen. I have had sacral fractures in the past that I've dealt with, and they're very easily visible. All you're looking for is that normal bone surface coming all the way back. And there is your first coccygeal vertebra or disc right here. So the sacrum comes back to the first coccygeal articulation, so that's sacrococcygeal disc, this little disc right here. And it's a good idea to do that as part of your survey. You can come back to the next disc space in that region, and these are quite visible here, and the next one back further still. Right here, this is a very large one, and this is right at the exit to the rectum, and we'll use that as our exit from the rectum. Slide number 1 demonstrates lumbosacral or L6 disc congenital ankylosis. When this occurs, the L5 disc is usually wider than normal, and that is the case on this slide. This type of congenital anatomical variation exists in 5 to 10% of the equine population. Slide number 2 shows L4, L5, and L6 discs. The L4 and L6 discs are good normal reference images, and the L5 disc reveals mild to moderate disc mineralization. Slide number 3 demonstrates significant lumbosacral or L6 disc pathology with disc protrusion, narrowing of the space, osteophyte formation, and mineralization of the disc. Slide number 4 demonstrates again congenital ankylosis of the L6 or lumbosacral disc, and the L5 disc space reveals fracture and fragmentation at the caudal aspect of the L5 vertebra at the disc space, and some mineralization of the disc as well. Slide number 5 shows two images. The left-hand image is a normal lumbosacral or L6 disc image. The right-hand image demonstrates tearing of the ventral longitudinal ligament and some disruption of the disc as well. Slide number 6 demonstrates very severe lumbosacral or L6 disc pathology. It's virtually unrecognizable on this slide, with severe degeneration of the L6 disc, fracture and fragmentation that are all demonstrable on this slide. Slide number 7 reveals again significant L6 or lumbosacral disc pathology with degeneration of the L6 disc and of the cranial sacrum at the disc space. Slide number 8 is a slide that demonstrates aortoiliac thrombosis. Normal reference images for the aorta and vena cava are on the top left image. Normal reference images for the iliac vessels are on the bottom left image. In the center are images that demonstrate the aortoiliac thrombosis of the aortic and vena cava in the top central image, and of the iliac vessels in the central bottom image. The two right-hand images demonstrate Doppler flow of blood around the aortoiliac thrombi. Slide number 9 demonstrates sublumbar lymph node placement just caudal to the aorta and vena cava. The normal reference image is on the left-hand side, and a melanoma mass, metastasis of melanoma, to these lymph nodes is demonstrated in the right-hand image. Slide number 10 demonstrates the normal transrectal pelvic anatomy in the pelvic roof. The sacrum is visible in the right-hand image with the sacral wings. The joint that is cranial to the sacral wings to either side are the lumbosacral intertransverse joints. The upper right-hand anatomical image demonstrates that to the left-hand side of that image, just forward of the L6 nerve root, and just lateral to the L6 disc space. The bottom images demonstrating the ultrasound appearance, the normal reference images. The left-hand image shows the small curved line demonstrating the lumbosacral intertransverse joints in normal reference appearance. Slide number 11 again shows a normal reference image on the upper left side of the slide. The central image demonstrates one normal lumbosacral intertransverse joint, and the left-hand image shows osteoarthritic remodeling with a significant osteophyte. And the bottom right-hand image again shows osteoarthritic remodeling or modeling of the lumbosacral intertransverse joint of significance on the left-hand side and milder on the right-hand side. Slide number 12 shows the anatomical appearance of the nerve foramini at L6, S1, and S2. And then central to that is an ultrasound image showing a normal reference image of the foramen and the nerve root that is between the caudal gluteal artery, which is dark, and the bright white surface of the foramen. Slide number 13 demonstrates pathology of the intervertebral foramen and of the nerve roots. The top left-hand image demonstrates an osteophyte at the foramen, and the other images demonstrate significant enlargement and edema of the L6 or lumbosacral intertransverse region, the L6 nerve root, the S1 nerve root, and the S2 nerve roots in succession. Slide number 14 again demonstrates the normal transrectal pelvic anatomy of the pelvic roof, again showing the sacrum with the sacral wings on the right-hand anatomical image, The sacroiliac joint is the caudal aspect of the articulation of the sacral wing with the wing of the ilium. In the central ultrasound image, the normal reference appearance for ultrasound of this joint, and this can be quite variable between individuals, but you can see the normal J shape of the sacrum and the line of the ilium next to that and the ventral sacral ligaments that cross that joint. These are normal reference images. Slide number 15 demonstrates several examples of sacroiliac joint pathology. The upper left-hand image, the right-hand portion of that image shows significant osteoarthritis with a large bony amalgam ventral to the joint space. The central ultrasound image at the top demonstrates an osteophyte on the right-hand image of that ultrasound. The top right ultrasound image demonstrates mild osteoarthritic modeling in the right-hand portion. The bottom right-hand image demonstrates subluxation and tearing of the ventral sacroiliac ligaments with avulsion fragments. This is demonstrated mainly on the right-hand portion of that image. And the bottom left-hand ultrasound image shows subluxation and tearing of the ventral sacroiliac ligaments as well, primarily again on the right-hand portion of that image, with a fairly normal reference image on the left-hand side. Slide number 16 demonstrates normal reference ultrasound images of the minor psoas tendons. The left-hand image is of the caudal aspect of the tendon at its enthesis and shows a small ovoid structure just dorsal to that tendon, which is the femoral nerve root in cross-section. The right-hand image shows the appearance of the minor psoas tendon as you travel cranially with your ultrasound and shows the musculotendinous junction with a mixture of tendinous fibers and muscle fibers. Slide number 17 shows pathology of the minor psoas tendon. The two upper hand images reveal a normal reference on the left-hand side and then tendinopathy on the right-hand side of both of those images. The two bottom ultrasound images demonstrate a tendinopathy and muscle disruption that's associated with that, again with the right-hand images being the abnormal and the reference images being on the left-hand side of those ultrasound images. Slide number 18 shows an anatomical specimen revealing the structure of the sacrum. The bottom ultrasound image demonstrates the lack of continuity of the ventral aspect of the sacrum, demonstrating a sacral fracture that has a step and fragmentation at the step. This should be a contiguous white line, and you can see that it is disrupted due to the sacral fracture. Slide number 19 reveals an anatomical image of the sacrum and coccygium, the cranial aspect of the coccygium where it articulates with the sacrum. And then the ultrasound and radiographic images demonstrate a coccygeal fracture at CY1/CY2 with displacement.